I'm Dr. Richard Senelick, and I'll be your host for this video presentation of Living with Brain Injury, a Guide for Families. We've been taking care of brain-injured patients for many years now, and over that time we noted that there was a need for educational materials, that families, patients, and even healthcare professionals needed some educational tools about brain injury. As a result, we started out by writing Living with Brain Injury, a Guide for Families, which is now about to go into its third printing. But as we also went through that experience, we realized that there was need for something that had more visual contact, that had more educational material that you could come back to again and again, and decided to go forward with this videotape series for Living with Brain Injury. We have a generous educational grant from both Allergan and Medtronic, and I'd like to thank them for their support of this videotape. Let's go ahead now and proceed with our journey of living with brain injury. The first thing to look at is how many brain injuries happen and why do people have brain injuries. It's not as uncommon as many people think. We all know someone with cancer, heart disease, a stroke in their family. But really, if you start to ask around, what you're going to find out is that there's a lot of families who've had brain injury visit their house. It's about 56,000 deaths a year, and about 400,000, almost 500,000 people end up in the hospital. What we're going to talk about today is this 100,000 people with severe to moderate head injuries. These are the folks that maybe have a severe automobile accident, end up in the intensive care unit, are unconscious for a period of time, and then end up needing prolonged rehabilitation. The question you ask is, who are these people? And who they are our sons and daughters. And indeed, they're really more our sons than our daughters. It's about 2 to 1. And here you first come about this experience, and if you think about it, is when my son first started to drive when he was 15 years old. I got this bill from the insurance company, who shall remain nameless. But I got this bill, and I couldn't believe it. So I dialed up and I called the insurance company, and I said, I've got this 15-year-old son who only has a learner's permit, and you want to charge me all this money so he can drive. And they said, that's right, Dr. Senelick, but he's 15 years old and he's a boy. And then all of a sudden, I started to think about it. That's who gets brain injuries. And why do 15 to 24-year-old young men get brain injuries? It's because they're impulsive, they're risk takers, they have bad judgment, they have aggressive behavior. I've been married at this point for 31 years, and what my wife says is that men start to become reasonable human beings about age 45 as we start to mellow out. So for all of you younger women who are watching this tape, there is hope for your significant other or for your spouse. The other thing to look at is the effect of alcohol. And if we look at how many people are intoxicated at the time that they're having their brain injury, or the person who hit them was intoxicated, it can be as high as 3/4 of the people. This slide that we're showing you now is an example of what takes place where I live in Texas and in many states. And this is a drive-through. You can actually drive right through, ask for the alcohol you need, and proceed. So that even though many states have open container laws, we all know that those aren't necessarily effective, and that drinking and driving is the cause of a large number of brain injuries and disabilities. Let's take a look then at what causes brain injury. We know that transport, cars, motorcycles, bicycles, buses are one of the major causes. Indeed, car accidents is the #1 cause in most communities. Motorcycles are a significant cause and are going to be on the rise even more for a couple of reasons. We're really seeing a resurgence of people buying motorcycles. Like the Harley-Davidson company is selling more and more motorcycles to people my age, to that 35 to 60-year-old group. And one of the big problems is that many states either don't have a motorcycle helmet law, or like my state in Texas, went ahead and repealed the motorcycle helmet law a few years ago. If you live in a state or an area that does a lot of construction, building skyscrapers, bridges, that's another cause. When we double-decked the freeway in San Antonio, Texas, we had a certain amount of injuries, and we had a couple brain-injured people that came off of that because they fell off of the top part while it was being constructed. When they build a skyscraper, or when they build a bridge or a dam, what's factored into that is that there's going to be a certain amount of injuries to include brain injuries. If we open up the newspaper or we watch television, we might think that the third category, the local knife and gun club, as I call them, are very active and that they're the cause for probably most brain injuries and spinal cord injury. Not for most, but still for a significant portion. And in some communities, the leading cause of spinal cord injury is actually gunshot wounds to the spine. If we look at older people, the over 65 group, and particularly if we look at the category of mild head injury, the causes are really a little different. Think about the number of times that you just sort of hit your head, like I'm underneath my car changing the oil, and I forget that I'm there and decide to stand up. Or in the morning, I'm sort of in a half daze and I'm brushing my teeth, and I forget that the medicine cabinet's open and I hit my head. We all have sort of these close calls. But for people over the age of 65, head injury starts to increase significantly for a variety of reasons. We don't see as good, we don't hear as good, our joints become stiff, the part of our nervous system that controls our balance, and so our toes tell us where we are at all time, isn't as good. So when we look at this, we can see that the leading cause of head injury, particularly mild head injury, over the age of 65, are domestic falls, falling at home. What the best thing you can do after you watch this tape is to go around your house and pick up all the loose throw rugs and put them someplace else. Even though I must admit I have them in my home and I'm trying to convince my wife that we need to remove them, but throw rugs and things that are loose in the house, bad lighting, can be significant causes for brain injury in the elderly. Trauma of itself is a significant problem. If we look at trauma as compared to cancer and heart disease, it really takes more of the heart of America out of work. We all know people with cancer and heart disease, and we see big gallows for cancer and heart disease. But brain injury really strikes people at their prime. Remember, we're talking 15 to 25-year-olds. And so by having that injury and becoming disabled, we're stopping their productivity and their contribution really to society. So that trauma really accounts for the loss of more potential working years and working life than even cancer and heart disease together. Particularly then, if we look at young people, trauma accounts for the leading cause of death under the age of 44. I found it's one of the great joys of being this age. It's one thing I can chalk up in that column that I don't have to worry about as the leading cause. It's the leading cause of death in children. What used to be an activity for children, but now more and more adults are getting involved in, is riding bicycles. And we all know this. Wherever we go, we're out on the weekend. I mean, we have mountain bikes, my wife and myself. And then there's this whole issue of bicycle helmets. We see this nice couple that had their bicycle helmets on, but if we really start to look around, you'll see that bicycle helmets are not being used by a lot of people. There's well over 1,000 deaths a year without the use of bicycle helmets from head injury. Look at this number. It's 181,000 brain injuries, head injuries a year from bicycle accidents. It's really a large number. But if you take helmet use and you look at those people where you mandated helmet use or communities went ahead and had a helmet use program, if you're wearing a helmet, it decreases your chance of getting a brain injury by 85%. We know that bicycle helmet laws decrease the incidence of brain injury. And you know what? It's not the kids who don't want to wear the helmet. If I look back and I think about my grown son, and when he was little, and we had to go to, Little League and soccer and basketball and all these activities, what he loved was the uniform. That was great. I mean, he wanted to go, stand in line, got the uniform. And once he got the uniform, his interest sort of waned. So the kids love the uniform. Kids will wear the helmet. The problem is really us parents going out, getting the helmet, role modeling that behavior so that when we go bicycle riding with our kids, it's not that it's okay for my son to have a helmet, but you know what, I'm a big boy, so I'll wear my Spurs cap from from San Antonio basketball. What we're going to do now is we're just going to want to warn you a little bit is we're going to look at anatomy. We're going to go ahead and look inside this head and see what is there. What is this magical computer that runs our body, allows me to speak to you today, allows you to see me and hear what I say. And they're very graphic slides, and that was why I wanted to give you a little warning. I'm going to show you an actual autopsy, a person who has died, and what actually it looks like inside the brain. So what we're going to look at now is a person who has died, who's laying on an autopsy table, and what you're going to see is the top of their head, is the scalp has been pulled back. So down here on the bottom is the scalp, which has been taken back, And you can see the skull here. We have on this is a shoulder off to the side, another shoulder off to the side, so this is the front. Underneath there would be the nose. And what you can see here are some fine little interdigitations. If you think of putting your fingers together, much like this, what we can see is along here runs the coronal suture, and here down the middle is what's called the sagittal suture. And if you do something, is remember when you pick up a young baby, a newborn baby, there's that great feeling, love to feel their skin, and then you kind of take your hand and you rub it over the top and you feel that soft spot. Well, that soft spot is right here, and that's the skull hasn't fused. So these interdigitations, or what are called sutures, are what allows the skull to grow as the brain grows. Otherwise, we'd all be stuck with this little brain we were born with. So much like in the sidewalk, if you live up north, I think probably down here in the south, we don't have too many of them, but you have expansion joints so that the cement doesn't crack as things expand and contract. This allows, this one, the coronal suture, the skull to grow from the front to the back, and the sagittal suture allows the skull to grow from side to side. It's kind of why we all look different. And they tend to close between the ages of about 16 and 21. Now, if this one, the coronal suture, closes first, and that's the one that allows our skull to grow from front to back, those are the folks that kind of look like they walked into a wall, and they have kind of a big, broad head and a flat face. On the other hand, if this one closes first, and the skull continues to grow this way, those are the folks with sort of a long, narrow heads, almost like the shape of a keel of a sailboat. What's important is that in children, they can expand these joints so that if they have a head injury and things start to swell inside, there's sort of a safety valve that they do better. Remember, this is a solid bone, and we're going to talk about this a little later about swelling inside the brain, but that's one of the biggest problems, is that this is a solid bone and the brain doesn't have any place to go on to the outside. Children have this expansion valve. Now what we're going to do is we're going to take one of those vibrating saws that orthopedic surgeons use if you've ever had a cast, and it kind of vibrates and it takes your cast off with cutting you. And we're going to go around and we're going to lift off the top and put it off here to the side. And what we're seeing now is the inside of the skull, and we're looking at a brain of someone who had just died recently. Now you can see at the bottom here is this tough leathery membrane, and I'm going to reach down and pretend that I'm pulling that back over and putting it on top. And that tough leathery membrane is what's called the dura, and that membrane surrounds the brain all around it inside the skull. So if we have a blood clot from being hit on the head on top of this tough leathery membrane and between the skull, that's called an epidural hematoma. What's more common, and we'll show you a picture of one, is a blood clot that's underneath this tough leathery membrane and on top of the surface of the brain, and that's a subdural hematoma. And we'll talk about that some more. The shiny, glistening membrane that you see on top of the brain, that's called the arachnoid. And down here, we've peeled away a little bit of that, and you see some fluid. And that's spinal fluid, and that's called the subarachnoid space. And that's where the spinal fluid is, and that's where blood can go after trauma. And we'll talk about that a little later, too. So I want you to remember these spaces: subdural space underneath this tough leathery membrane, and subarachnoid space underneath this glistening membrane and between the brain and having the spinal fluid. The other thing you'll notice is that the brain is folded. It's squiggly. It almost looks like some worms in there. And there's a reason for that. And I'm going to take this sheet of paper to kind of give you an explanation of that. If we look at lizards, snakes, and just pretend that like we were amphibians and you're sitting around a pond in prehistoric times, and all you had to do was lay in the sun and snag flies. There really wasn't a whole lot else you had to do. Maybe watch out for dinosaurs, but not too much else. You didn't need a lot of brain power. So the brain was really kind of smooth. But as we started to evolve and become more sophisticated, and we needed more brain power, we couldn't just write off to the computer company back then and get more microchips to put inside our head. we needed to create more brain power. But yet, the head can only be so big. You can't have a head this big. So how did it happen? If I take this sheet of paper and I write on both sides of it, I can store this much information. But now, if I fold it like an accordion, I was never good at this. They almost failed me in kindergarten for this type of task. But now I have folded this sheet of paper, and guess what? I stored the same amount of information in this much space. And that's what happened with the brain. It's folded. So if you look at this sheet of paper, and then look here, what you see is that it has folded creases areas or valleys, and it also has peaks or the top. And these correlate with the brain on the other side. So we have where we store more information on the inside and then on the top. The other thing to look at is that up here on the top, you can see how thick the skull is. And we're going to come down to where the ear is on the side, and it's much thinner. There's a reason for this. If we think about animals butting their heads in combat, how we usually hit our head, the thickest part being in the front and the back is a natural protective mechanism. But the problem is that we usually get skull fractures through the side, through this thin part, and it's why in boxing the worst blows, the most lethal blows, are those that come to the side of the head where the skull is the thinnest. The other thing I really want you to keep in mind from this slide, which we're going to talk about later, is the space. We have space up top here between the brain and between the inside of the skull. It's not totally packed in there. There's room for movement. There's spinal fluid in there that kind of floats the brain inside the skull. And there's also this space where the brain can move and move backwards and move side to side. And when we go a little further, we're going to talk about that. The brain itself is not pain sensitive. And that's why you can turn on your television and you see these television shows where somebody's got a needle or a probe inside the brain and the patient's perfectly awake and they're doing surgery on them. And you say, my goodness, how can they do that? It's because the lining of the brain that we showed you is pain sensitive, but the brain itself isn't. The brain is kind of soft and squishy. And so what we're going to do is we're going to reach underneath with a little knife and we're going to cut out this brain and we're going to lift it out and we're going to put it aside. And what we're going to see now is the inside of the skull. And there's some important things here to look at. Let's first look, we talked about how thick the skull is on the bottom and up on the top, and then how thin it is on the side, so that most fractures really occur right through here, and these are called basilar skull fractures, and they'll go through this thin part, down through here, and down through where these other nerves are that control hearing in the face, which we'll show you in a little more detail. The front part of the brain, our frontal lobes, sit up here in the top part, what's called the frontal fossa. And now we're going to ski down off this sharp edge, and that's the middle fossa, and that's where the temporal lobes sit, the lobes on the side of our brain. And those two parts of the brain are most vulnerable in brain injury because they can slam up against the inside of the skull with movement. We're going to come back down, and this back part is called the posterior fossa. It's where the cerebellum sits, and the brainstem. It's the part that controls heartbeat, respiration, our mouth movements, eye movements, and coordination. You can see that we keep our computer in what looks like a much safer place. You know, we put it in a padded case that has foam, and here's the inside of the skull with all these sharp edges and drop-offs. Way up front here is called the cribriform plate, and it's an area where little fibers come through to allow us to smell. And it's why frequently they get torn in brain injury, and people can't smell or lose their sense of smell after a significant brain injury. If we come further down the middle, in the center is the pituitary gland, and then off each side is the optic nerve. Our eyeballs sit underneath here. This is the carotid artery, and that's the main artery that takes the blood to our brain. And you would think it'd be this big hose, but this little artery supplies all the blood that goes up to one side of the brain. Then what we have inside here are all these little things that kind of look like linguini, and look what a bunch of different ones that are kind of hanging there, and these are called the cranial nerves. And they come from the brain, and they kind of float in the spinal fluid, and they go forward to supply the muscles that move the eyes. And that's why frequently they'll get stretched or torn, and people will have double vision. They'll have an eye muscle that doesn't move. The eyes don't line up. It can go through here when a basilar skull fracture, if we see these little linguinis, cranial nerves sitting here, that can affect our ability to hear, so you can lose hearing, or the ability to move the face, these cranial nerves. It can affect swallowing. If we go down from this area, we see this hole, which is called the foramen magnum. And within this hole is the spinal cord. And you can see how small it is, so that all the information that's taking place up here in my brain and has to come down to move my hands, to regulate all the functions of my body, goes through an area that's no bigger round than my index finger. And it's why spinal cord injuries are so devastating, in that it only takes a small injury to cause total paralysis or loss of function below that level. And the last thing we want to show you is what happens when the brain swells in here. Remember I said that this is a hard bone and the brain's sitting in here. So if I go up to this gentleman sitting over here and I hit him with a hammer on his arm, he'll get, in the Texas, what we call a pone. He'll get a big swelling on the side of his arm, and it'll swell outward. And what will end up is something that'll swell, and it'll turn all kinds of wonderful colors. It'll turn blue and purple and yellow and green, but it'll go away. Well, now what I'm going to do is go up to him, and I'm going to hit him on the head with a hammer. Well, all of a sudden, we may get a little swelling here, but if he gets a hemorrhage or a swelling or a pone inside this skull, where's it going to go? Remember, it can't swell outward because the skull is solid, and so it can only swell inside. And it's that pressure and swelling that one of the biggest problems in brain injury. And what happens is as the brain swells, it starts to push over these edges, this edge right here and on the other side, and it's going to press on this brainstem. If we go ahead and look at my hand and remember that this is the brain, and this is the brainstem, and down here is the spinal cord, we're talking about the top part of the brain swelling and then pressing down on this part, the brainstem, the part that controls heartbeat and respiration. And that's frequently why people will die or stop breathing, and it's such an emergency in severe brain injuries, is to control that swelling, and if the swelling does go over and press on that part, then to take over for breathing and for heartbeat. Let's look at the mechanisms of why brain injuries happen. What's happening inside the head? The way to think about these is acceleration and deceleration injuries. Is it you're moving and suddenly stop, or something else is moving and suddenly stops? Also, we're going to show you some examples of rotational injuries, as the brain can rotate on its axis and what happens. So let's go ahead and we're going to show you a picture of somebody in a car. And so you're driving along the freeway and you're going at 60 miles an hour and everything's relaxed. Our friend here looks relaxed, maybe looks a little too relaxed. And what happens is all of a sudden he smacks into a concrete abutment. And the car's going 60 miles an hour and the car stops suddenly. Well, he's going 60 miles an hour and this poor fellow didn't have his seatbelt on, which is a real problem also that we have. And he goes forward and his head hits the windshield of the car. So that the car stopped first, now he stopped. Well, let's look inside his head and see what was happening. The skull hit the windshield, but remember the brain was still going 60 miles an hour also, so that the brain now moves and slams up against the front of the skull and then comes back. And what we end up with is these bruised areas and also strained nerves. We'll look here first at the bruised areas. And if you remember when we showed you the skull, we had that area up in the front, and we dropped off into the temporal lobe area, the middle fossa. And these pink areas show then the frontal lobes. This is the temporal lobe. Parietal lobe, this is the part we see with. Here's that brainstem, and this is cerebellum for coordination. But that these areas become bruised because they slammed up against the front of the brain. The other thing that can happen is that the brain can twist and it can rotate. So if we look at a brain here, and then we see that it's connected by the brainstem, and it can move from side to side. And when it does that, you can end up with damage sitting down in that brainstem, so that this lower area, remember my hand was connected here, and it could turn, and we'd get these changes. Well, what can happen is the brain, I'm going to grab one of these wires here, is connected by these axons, and we can get what's called axonal strains, so that we go from nerve fiber to nerve fiber connected with this wire. And what happens is that they can get stretched inside the brain. So as it stopped, these wires got stretched. Now they can just be strained, and we have a red one here, which I'm going to try, and they may, where the insulation on them just tears apart, and they'll be able to heal themselves. If I had a big cutter, I could cut this in half, and we could see that they would absolutely not be connected and may not regrow. So determining whether somebody gets better or not can depend on whether these fibers that connect the inside of the brain are just stretched and torn with this insulation stretched, or whether they're actually getting cut. We talked about that brainstem injury, and I'm going to show you some pictures more of that and what happens. And then the last thing to talk about here is diffuse axonal injury, which is the most common thing that happens. That even though you may only see a bruise on the front of the brain, remember that inside, all of these nerve fibers on both sides of the brain can get stretched or torn. It's not just the area where you see the bruise where the person got hit, but the inside and throughout both sides of the brain. Let's now look at the different types of brain injuries. We can look at skull fractures, and skull fractures can be depressed, like taking a ping pong ball and dropping your finger on it, and it presses it inside. This is more common in children. We like to go in and pick that up or pop it out because those children can develop seizures. The others are compound fractures, where bone and hair or dirt can go inside the skull. The other thing to talk about are bullets, missile injuries. So we see patients that survive 22 calibers, but we don't see too many people that survive large caliber, because the amount of damage that's done to tissue is dependent upon how fast that bullet is going. It creates a shock wave around it. It's why when you're hunting, you can bring down large animal with a high velocity bullet. So people who are shot in the head with a .22 usually survive with brain injuries. People who are shot with much larger caliber or higher velocity causes more damage and don't. What we're really going to talk about now is the different types of closed head injuries where the skull stays intact and nothing really goes inside. If you remember earlier, I went ahead and took a hammer and hit this gentleman, and he got a swelling. And that's a contusion or a bruise. It's what you get if you're walking along and you strike your shin and it gets swollen and sore. A hemorrhage is where a blood vessel actually breaks. And if you think about taking a hose and spraying it in the snow and it makes a hole and destroys the snow, if a blood vessel breaks inside the brain, you can get a hemorrhage and it destroys that part of the brain. An infarction is like a heart attack or a stroke. It's like we have myocardial infarction, where a blood vessel closes off and you get damage to the heart muscle, or if a blood vessel in the brain closes off and you get damaged brain that dies, or a stroke. Now those are focal. They just happen in a small area. But remember, we were just talking about that brain injury usually involves both sides of the brain because those nerves get stretched. And we call that diffuse axonal injury. But something that frequently gets forgotten is what's called hypoxic ischemic damage. So in your community, you have somebody who's out on a freeway and they have an automobile accident and they're on the ground and EMS shows up and the helicopter shows up and they rush them to the trauma center and they have a punctured lung and they have a ruptured spleen and a bunch of bones that are broken, and they fix all of that and they save their life. 3 days later, they start to remove the tubes, and the gentleman's wife says, you saved his life, but Bill's different. Bill isn't the same person. Bill's acting funny. Well, what happened was while Bill was laying on the ground with a punctured lung and a ruptured spleen, He wasn't getting enough blood to his brain, and he wasn't getting enough oxygen to his brain. So that we need to carefully look at patients who've had multi-trauma and see, have they had a brain injury? The same thing with spinal cord injury. Many spinal cord injuries happen in automobile accidents or with falls, and if the force was great enough to cause a spinal cord injury, it frequently also causes a brain injury in at least about 35% of patients will also have a brain injury. Let's take a peek then inside the brain at some of these actual brain injuries. I got you prepared before for what we were going to see, and now what we're seeing is the skull removed. And remember we talked about that tough leathery membrane? I'm going to reach down again. So I'm going to reach down here, and I'm going to pull up this tough leathery membrane, and I'm going to put it over the top. Now I'm going to pull it down. So where's the clot? The clot is a subdural hematoma. It's a big blood clot that's sitting between the lining on top of the brain and the brain itself. These are big, fresh, what are called acute subdural hematomas from a terrible automobile accident. Now the other thing, remember, we've got this poor guy here that I hit, must have been 30 minutes ago, with the hammer on his head. Remember that? And we said that the swelling had no place to go because of this hard skull. And that's what happened here. You can almost see the brain coming out at you because of the pressure being exerted by these blood clots on either side of the brain. And so what's happening is that the brain is getting squeezed, it's getting pushed, and where did we just talk about a little bit earlier? It's going to go down into that foramen magnum, over those edges, and you're going to get brain herniation. Now what we're going to do is look at a hemorrhage inside the brain. And this is a picture as if I'm going to stand forward here, and you slice me open from the front and look inside at me. So we've taken a brain and we've sliced it. And so we have the right side of the brain and the left side of the brain. And over here on the right side of the brain, we can see this space, and that's called a ventricle. It's where the spinal fluid is. Over here, we have this big blood clot. And so if you said, well, that's what the patient died of. Well, it's what started the problem. But if we look around this blood clot, we see something else. What we really see is a lot of swelling and edema, so that all of this gray material around the blood clot is fluid or edema. And look what it's doing. See the slit? That should look like the ventricle on the other side, but it's pushing the brain from one side to the other. It's pushing the brain downward, and where do we say that's going to go? It's going to go over the edge, press on the part, the brainstem that controls heartbeat and respiration, and patients stop breathing. So although we say the patient had an intracerebral bleed in the brain, it's the edema or the swelling that led to their death. Now the next one is a blood vessel that breaks inside, not inside the brain, but inside the lining. So that when someone has an aneurysm, an outpouching, think about a tire that is getting worn and it starts to get a bubble on it and then breaks. That's what happens with an aneurysm. Well, people can also have a tearing of blood vessels on the surface of the brain when they get hit on the head or in a car accident. And this is called a subarachnoid hemorrhage. So remember earlier I showed you that space with a shiny lining of the brain, and we peeled it back. And now what we're seeing here is blood all through underneath this lining. This is the front of the brain, the back of the brain, and this is the brain stem and the cerebellum. Now the brain is real particular. It loves to have blood inside blood vessels, but it really doesn't like to have blood outside blood vessels. It causes them to go into spasm, to clamp down, and you end up with strokes or damage to both sides of the brain. The last thing we're going to do is we're going to cut through this brainstem here, and we're going to take a look at the inside of the brainstem. And so we have folded this up. And here we have an area called the pons. This is the middle part of the brainstem. And the cerebellum on either side. And that's the part that controls our movement and makes it smooth. But what I really want to talk about is this middle part where these hemorrhages are, and in this area right here. I want to reorient you so you're not lost. And we'll make the fist again. And this is the brain. The middle part here is the brain stem that we have cut open. And now we also have the spinal cord coming down here. Now in this area, right here, is what's called the reticular activating system. It's about 1.5 inches long, about as big around as the head of a pin, and it's firing and sending signals up to the top part of the brain to keep us awake and alert. Hopefully you're awake and alert now. It's working. If a patient has a brainstem injury, and if you remember earlier we showed you how the brain can twist sometimes and damages this part of the brain and causes hemorrhages, then that part of the brain, the reticular activating system, can be damaged and the patient may stay in a coma. The top part of the brain may be perfectly normal, but this little part that sends the signals to keep us awake is damaged and a patient may never wake up. Let's take a look now at the things we use to predict recovery on who will recover and who may not. There's some real simple things in trying to do it, and one is what's called resolution of temporary factors. Is that when the patient is in the intensive care unit, their blood pressure is low, their oxygen level is low, maybe they had some swelling in the brain that went away, and these are the folks that get better really quickly. But we really want to look at is another group of patients, and that's the patients with a much more severe injury who aren't getting better. And one of the theories is that the connections throughout the brain get modified. Think about going spring, my wife will probably tell me I'm wrong, but whenever you do your crepe myrtles and trim them back, and what happens is that they tend to sprout and they grow. Well, the same thing happens in the brain. Remember, we had all these nice colored wires they gave me, and these are these wires that connect one brain cell with another, and they connect one to the other. But now they're either torn or they're stretched, the red one we stretched, and the key is they start to sprout. They start to grow off just like that crepe myrtle, and they start to connect. Now, I went into the basement of this building before we started this lecture and did this to the phone system. I cut all these wires, and people got really upset, but only for a short period of time. And you say, how did I know how to fix this? Is because what I did is I went ahead, and on the next slide you'll see I connected blue with blue, yellow with yellow, black with black, and green with green. It was pretty easy. These are color-coded. The problem is that the brain doesn't have conduits. It doesn't have a nice conduit or tube for this red wire to run in so that once it's cut and it starts to grow, it can just grow one to the other. What we want to look at is how does the brain rewire itself? And this is some fascinating new research that we're finding out, is that the brain is capable of rewiring itself. And what they've done is some research in monkeys, where they've gone ahead and given a monkey a stroke. And it caused the monkey to have paralysis, let's say, of the right arm and the right leg. And then they studied the part of the brain to see what happened to that part of the brain that they destroyed. Well, that part of the brain stayed the same. But with rehabilitation and exercise and therapy, they were able to turn on another part of the brain next to it, and that part of the brain was able to take over the function of the arm and leg. And that's called plasticity, that the brain is plastic, and that there's a way for it to kind of rewire itself and have an area of the brain take over and take over the function. One of the really important parts of this for rehabilitation is that therapy made a huge difference, is that those monkeys that were just kind of left alone, they got a little bit better. But that those patients, those monkeys that got monkey therapy, got a whole lot better. And so that the actual movement and the actual performance of therapy does something to stimulate back into the brain, to have the brain reorganize itself, and to actually figure out how to rewire itself. The next thing we're looking at is there's something that you can give in the way of a drug called a neuroprotective agent at the time that the patient is hurt. So is there something that you can give out at the scene of the accident? Is there something that the EMS technician can give, something they can inject, or something in the emergency room that'll stop these brain cells from dying? But once there's damage, brain cells start to swell, they start to have all kinds of chemical changes. And we're starting to look at and study is a whole bunch of different drugs that you can give, and hopefully one we can give easily, that'll stop that process and really prevent more brain damage from happening. Let's look for a minute then on how do you predict who's going to get better and who isn't. There's three real crucial factors to look at. The first is pretty easy, and that's how bad was the patient hurt to start with. And that's a pretty good predictor. People with mild brain injury are clearly going to do better than people with severe brain injury. So the degree of the damage to the brain is a rough indicator of predictor of outcome. The next, which I think is one of the most important, is the rate of recovery. If the patient is in the acute care hospital, in the intensive care unit, and they're getting better like this, that every day you see improvement, you go back to what you used to do when you were in grade school and you connect the dots. And you connect this dot with this dot with this dot, and you can see, ooh, we're getting better. On the other hand, if the patient was over in the regular acute care hospital for a month before they came to see me for rehabilitation, and we start to connect the dots, and they started here, and we're connecting the dots, and a month later we're only to here, I'm a little worried, because as I start to connect those dots out further and further, I'm not getting as good a result as I did with the other patient. So the speed of recovery is important. The age of the time of injury is also very important, because we want to look at the fact that children tend to do better than adults, and middle-aged adults tend to do better than older people, is that there's less reserve. We call that cognitive reserve. I have less brain cells today than I had when I was 20 years old, so that I'm less capable of taking an insult to my brain than my son is. The other thing is to look at the predictors of the severity. How severe was the injury? We're trying to figure out, you know, is somebody really brain injured badly? And this becomes more of an issue with mild head injury. There's a thing called the Glasgow Coma Scale and another called post-traumatic amnesia. And first we're really going to do this backwards and look at post-traumatic amnesia. And post-traumatic amnesia is really the loss of memory or the time between the injury and when people start to recover their memory. And you can look at it in three things that you test for when you're looking for. And you look at what time does the patient become lucid or clear. So remember, let's say we're in the intensive care unit, you're visiting your family member, and at what time are they aware that you're there? When do they remember the events from time to time? The trouble we get into as physicians all the time is that you come in to visit if you're a family member and they say the doctor was never here, because they can't remember continuous events from time to time. They have no carryover. And the last is being oriented, knowing what time and what place they're at. And we'll settle for just that for post-traumatic amnesia, not even knowing that they were in an accident, but do you know who you are, do you know about what time of day it is and where you are. And if we take post-traumatic amnesia, we can grade it and we can put it into different levels. Someone, you know, Bubba gets hit on a football game on Friday night and gets a ding, and he's confused for a short period of time. He has post-traumatic amnesia of less than an hour. That's a mild head injury. But as soon as we get beyond an hour to 24 hours, we're getting into moderate head injury. And you can see that if it lasts more than a day, it may represent a severe injury. So that a lot of times I deal with families who say, you know, my husband was in the ICU, but on the fourth day he started to wake up, and after a week he started to recognize me, and isn't that great? And the answer is yes, that is wonderful, and that's great, but it still doesn't mean that there wasn't a lot of brain damage, and it still puts the patient into the very severe brain injured category. The Glasgow Coma Scale is a scale that's really used predominantly as we call a triage tool, used in the ambulance and the emergency room, and it's used to predict big categories of who's going to live and who's going to die. It was developed in Scotland, and it basically takes these three different functions, eye-opening, the ability to move, and the ability to speak, and gives them a score. And I'm really not going to cover that here other than let you know it exists. It's used mainly in the emergency room, but it is just not a good predictor other than life and death of how well somebody's going to do. It's not a good predictor of who's going to go home and who's going to be independent. Now, if we think about the different categories of what happens to you when you have a brain injury, remember we looked inside the brain, We showed you the different parts of the brain. We showed you that the nerves get stretched and the different parts of hemorrhages. But what you really want to know is, how does it affect me? How does it affect the patient? And really, you can think of things in three major categories. They fall into physical problems, they fall into behavior problems, and cognitive and thinking problems. So we're going to first look at is the movement problems, the physical problems. The most obvious that everybody sees is that you can get paralysis. So that if one side of the brain is more damaged than the other, you may have paralysis on just one side of the body. That if the left side of the brain is damaged, the right side may be paralyzed. If you have a diffuse injury, there may be paralysis of both arms and both legs. One of the things that happens over time, and we're going to talk about after this, is spasticity, is that the brain can react in an abnormal way and that the muscles can become tight, so that we call spasticity increased muscle tone. Initially after an injury, all the muscles may be loose and floppy, and the patient, if they're in a coma, may have no movement at all. But over time, you may see an arm start to pull up and draw up and a hand start to make a fist, because there's increased tone, there's increased activity in these muscles. And frequently, the arm then becomes flexed in this posture with a fist, and then the leg becomes extended in a straight position with the toes pointed down. We're going to talk in a little later about how to deal with that spasticity. Speech can become involved, just as if I lose my tongue periodically throughout this talk and get a little glitch here and there, you can have a speech disturbance from a brain injury, where your speech will be slurred, just like that, or thick, or you may not be able to find the word that you want to use. Remember those spaghetti strings that I showed you? The linguini that was sort of in the bottom of the skull and going from one place to the other? Well, there's three of them that go into each orbit, or where the eye is, and they control eye movements. So if that cranial nerve, the third or the fourth or the sixth, gets stretched or torn, then the eyes don't line up. Our eyes are kind of yoked together. I don't know if you can remember what oxen pulling a cart looked like when we went across the West, and they had a yoke over their neck. And that was so that if one turned this way, the other went with them. Well, we have a mechanism within our brain that does that. It yokes our eyes together so that if this one goes right, this one goes with it. Stays lined up so that we don't see double. If one of those nerves gets stretched or the computer gets damaged, the eyes then are not lined up and people see double. Depends on whether the nerve is stretched or torn as to whether that's going to improve with time, but there's lots of things we can do for that. Seizures. Seizures are much more common if there's a blood clot or a hemorrhage. If it's just a closed head injury, the chances of seizures are really quite small, and we usually don't put people on seizure medications for just having a closed head injury and not having a blood clot or not having a break in the skull or surgery. And finally, is headaches are really an unusual thing. If I look at my patients who have severe brain injuries, it's really unusual for them to have complaints of headache. On the other hand, if we look at our patients who have a mild head injury, the person who slipped on a wet floor or on the ice, the person who was in a car accident, hit their head and was just stunned, headaches are a huge problem. And we really don't understand why headaches are such a big problem for people with mild head injury, but not for people with severe head injuries. Let's focus in on this spasticity, because we've had some exciting things that we can really do for that. The first thing that I didn't put here is therapy. Is that from the day a patient really is injured, and certainly from the day they're getting rehabilitation, there's a good deal of physical and occupational therapy going on to try and stretch these muscles out. So if they're getting tight, the therapist may put a splint on the wrist or a splint on the foot, and to continue to try and stretch the muscles. But a lot of times that's just not enough to control the spasticity. In spasticity, this tightness can interfere with the ability to use a hand or a foot. It can interfere with hygiene. If a hand is so closed and so spastic, you can't open it, then you can't clean it. The same with the legs. If they're tightly together, you may not be able to spread the legs apart to clean someone after they urinate or after they have a bowel movement, or just for normal hygiene. We have a number of medications that can be given by mouth to try and decrease the spasticity. But two of the new really exciting things that we've been doing are Botox or botulinum toxin, and also putting in pumps that pump fluid into the spinal fluid to decrease the spasticity. The first is Botox. What Botox is I like to think of it as an old foe and a new friend, in that it's botulinum toxin. This is the toxin that, you know, if grandma canned her tomatoes and didn't do them right and they sat too long, and you could get botulism. Well, if they purified this into a very tiny toxin and make very small amounts of it, we can inject it into muscles in very small amounts, and it weakens the muscle. So that if someone has a spastic hand, we can go ahead and inject a small amount of this medicine into these muscles, and in about 2 or 3 weeks, the hand will open up and the muscles will become loose. And so we use this selectively, particularly for muscles in the hand and for some in the legs. When Botox by itself and the medicine doesn't work, then we may look at putting in what's called an intrathecal baclofen pump. So that one of the medicines we give by mouth is called baclofen to decrease spasticity. But if we can give it in tiny amounts into the spinal fluid that goes around the spinal cord and around the brain, we can really decrease spasticity dramatically, particularly in legs. And so people have created, Medtronic's company, an implantable pump. We see it here, this round cylinder, and a catheter that goes around it. And we see next is that you can take this pump and you can implant it right here in the abdomen, and a plastic tube can go around into the back and infuse or put in this liquid, intrathecal baclofen, in tiny amounts, and it'll just keep dripping it slowly in and decrease the spasticity. You only have to refill these pumps about once every 90 days. Battery will last for anywhere from 3 to 5 years. And for a lot of our patients, it's turned out to just be a spectacular way to decrease their spasticity. Many of our patients require Botox, injecting the medicine to control spasticity in the upper extremity, and then also using a pump to control spasticity in the lower extremities. One of the other areas then to look at, after talking about physical, is to look at cognitive disability and cognitive deficits. We've talked about the physical deficits that happen to people. And as devastating as they can be, they're usually not the limiting factor. I have lots of patients who travel around the world functioning from a wheelchair, run major companies, and do all kinds of things so that people can overcome physical disabilities much more easily than they can overcome cognitive and behavioral disabilities. And cognitive is to know, or it's the way we think. And let's look at some of the things then that happen to patients after they've had a brain injury. Remember that most injuries are diffuse injuries involving both sides of the brain. If you ask typical patient, layman, or even many doctors and say, well, name some cognitive deficits for me, they'd say, well, remembering, troubles with memory. But the problem really starts at a much more basic level, and it's really our ability to attend or to concentrate. Our ability to pay attention is required for our ability to remember things and our ability to learn. And attention can come in different forms. You all ever wonder how your children can study with the television on? And you go in and say, you shouldn't do that. Turn it off, or the radio, or MTV, or whatever they're listening to. Well, they have selective and divided attention. Their brain is intact, just as hopefully ours is, and they can tune that out, that they can focus on the task at hand with another noise. So that as I'm standing here today and we're taping this, there are people in this room, there are lights, there are people up and moving around, there are monitors, there's sounds, there's an air conditioning noise. But my brain allows me to tune those out and to have selective attention, to pay attention to the task at hand, that I have to give this talk and make this tape. The same happens to you. When someone has a brain injury, attention is affected in almost all of them. So the ability to attend to tasks, to pay attention. In many of my severe brain injured survivors, that attention span can be 5 seconds. So initially when they're seen in the hospital, the therapist can only work in very small segments. And you can only, because after 5 seconds, they're off looking away and doing something else. Think of children with attention deficit disorder. We used to call these hyperactive children. Their difficulty is attending to tasks. since they can't pay attention to this task in school, they become distracted, start to look around. And then as they get distracted, they may also have the hyperactive part, but they can't learn because they're having problems paying attention and become distracted. Same thing with the brain injury population. Another really important set of functions are what are called executive functions, and they reside right up here in the frontal lobes. And that's this group that falls under initiation, goal direction, judgment, and perception. It's really what makes us successful, is who you want as your doctor is not who sat in the front row with colored pencils and was #1 in the class. That may be the best doctor, what you really want is the doctor with the best judgment who's going to make the right decision at the right time. So what makes somebody successful in whatever profession they choose to do? Pick whatever you want, whether it be an accountant, a lawyer, running your own business, a programmer. It's initiation, goal direction, judgment, and perception. It's these executive functions. All teenagers lack executive functions. I mean, I would remember I would walk into my son's room when he was in high school, and I can tell all these stories because he's grown and beyond all this, but we'd be ready to go to bed, and I'd say, don't you have a term paper due tomorrow? Yeah. And I'd say, well, have you started it? He'd say, no. And I'd say, well, are you going to? And he'd say, Dad, you worry too much. And so there's this whole problem with initiation, getting started, being goal-directed to the task, and judgment and perception we know teenagers have a big problem with. That tends to come together, and people who have those as really good skills are the people who say, gee, they're a self-starter. They really get the project done. They're well organized, and then one of the most important things is their judgment. They make the right decision at the right time. Well, this is one of the biggest problems, particularly in high-level brain-injured patients. So take a doctor, lawyer, accountant, nurse, therapist, executive secretary, banker, anybody with a higher level job, businessman, who now is walking, looks like me, has no physical problems, but has executive function problems. And now we have these problems with initiation, goal direction, judgment, and perception. So now let's say that my secretary had a bad brain injury and comes back to work and has problems with executive functions. And I say, here's a project I'd like you to do. And I come back the next 2-3 days and nothing's been done. There's no initiation. There's no goal direction. And this is a big problem with brain injured patients, are what are called executive functions. The top part leads to then learning and memory. And then another thing is speed of information processing. The rate at which information goes in and the rate at which information goes out is that we process information really quite quickly. I'm talking relatively rapidly. You're absorbing that information and understanding it. If you have a brain injury and I come up to you and I say, good morning, how are you? And I don't wait and I say, well, what did you have for breakfast? What are you going to do today? Someone with a brain injury is still trying to process that first, how do you feel? Is that information is going in very slowly and being processed very slowly. We call that a latency of response. Our therapists are the most patient people in the world, is that you have to sit and wait for the response, and it gets processed, and then the information comes out slowly. And that can be a very limiting step in the ability to get someone back to work. We live in an environment that is what's called competitive employment, in that you're expected to do a certain amount of work in a certain amount of time, and that's measured. So now if you can perform that work but perform it very slowly, or need an environment that doesn't have distractions so you can pay attention, you can be very limited in the ability to find employment. So we work on these things in rehabilitation. We work on speed of information processing. We work on adding distractions, starting first in a quiet environment and then giving more and more distractions. And then we work on communication and language. And we can do a good job with this and get people back into the work environment, back into home, and back into the community. But a big problem, and a bigger problem for us than cognition, can really be behavior problems, what we call behavioral disability. There's a quote that I really like, which came from a neuropsychologist called Barry Rath, which says, "That which makes us most human is most vulnerable to head injury." And that which makes us most human is really this ability to form relationships. In 31 years ago, well, probably before that, we've been married 31 years, so let's say 33 years ago, when my wife, and myself met each other, there was something about me that she liked. I guarantee you there was a lot she didn't like. But there was this part she fell in love with. And that's what, we can't measure. And so as we've gone on for these 31 years, she's there because there's this part that she's in love with. Now, trust me, there's still all of this here that she doesn't like. But she says, I can handle that because of this. Well, now I have a brain injury. And I've become someone else. And the part which made us most human, which is that relationship, the part that forms a pair or a partnership, and the part that you love in someone, or if it's your child, the part that you recognize that this is my child, not somebody else's child, is lost, then we have a big problem. I have families who tell me, the last time I saw my son, he was one person, and I'm taking home somebody else from the hospital. I love them, and I love them just as much, but I'm taking home a different person. So that ability to form relationships can be a real problem. Let's look at some of the other changes that take place in behavior. The key is, who was this person before they had a brain injury? Brain injuries tend to exaggerate or exacerbate pre-existing traits. So if I'm a 18-year-old alcoholic, drug abusive, risk-taking, impulsive gang member and have a brain injury, I'm probably not going to be able to turn you into, Mother Teresa. It's not going to happen. What's going to happen is those pre-existing traits are going to get worse. So we're very much interested when we talk to families and say, what was Jim like before the head injury? Was he laid back and relaxed? Was he aggressive, irritable, difficult to deal with, and short-tempered? Because frequently, those behavioral traits are going to be worse after a brain injury. Maybe not at first, but certainly over time. We may see apathy or this lack of initiation. I have families that tell me, my wife, she just sits around the house all day. What you're really seeing is a lack of initiation. The ability to say, well, wait a minute, here's my list of things I need to do, or I need to get up and do them. There's no start. There's nothing that gets you up and going. The biggest problem is really social inappropriateness. And the example I like to use is, at least where I live, many of the grocery stores and large food chains use people with developmental disabilities to take your groceries out. So that you go through the grocery line, and maybe you're upset with the checker because they're always too slow. But you've got your groceries, and now you're in a hurry to get home, and the person taking your groceries out is someone who's developmentally retarded. And even though you're in a hurry, you say, but this is okay. This is a good thing. Look at this company. They're doing a wonderful thing for this individual. This person has a job. They're back in the community with social interaction. And you kind of take a deep breath, and you walk slowly to your car, and you say, this is good. And you feel good about it. Now the problem is, we have one of my brain-injured young people working at the same grocery store, and they're socially inappropriate, and they may be sexually inappropriate. And all of a sudden, the conversation changes to something that's absolutely inappropriate, or I'm getting pinched. And all of a sudden, I find that myself or my wife or you are going and talking to the manager, and my brain-injured patient is let go. So we as a society, we tolerate people who are slow. We all work with people who we wish worked a little faster. We live with people who maybe we wish were a little faster. But what we don't tolerate is social inappropriateness. So think of the problem of, if I am a brain-injured, I'm the parent of a brain-injured survivor, and I have a 17-year-old son who's brain-injured, and he's socially and sexually inappropriate, and I'm bringing him home, and I have a 14-year-old daughter who likes to have her friends come over to the house. I have a serious problem to deal with. So the behavioral issues tend to be some of the major stumbling blocks for us, and ones we have to deal with, and really have to be dealt with a lot of counseling, a lot of behavioral therapy, and also a lot of medication use, which can affect behavior without affecting thinking. We become much better at doing those things. And the last thing is, remember, We said what got a lot of these folks in trouble to start with was being impulsive and risk-taking. Well, a lot of that sensor, that things that keeps us from doing that, is lost. And so all of a sudden we find our brain-injured patients are now more impulsive, they act without thinking, and more easily distracted, so they get in trouble. All of us have, hopefully, like a social sensor and a sensor that keeps us from doing things. We'll have thoughts. We'll be driving down the highway, and somebody cuts us off, and we start to act on it. And then we go, oof, I'm not going to do that. But if you're impulsive, you say, I'm after him. Put the pedal down, and road rage starts. You may just act on a whimsy and say, you know what? I need a new car. I'm going to just go do it. We would work through the mental process and say, yes, but I can't afford it, or I can't afford it for 6 months. A brain-injured person would be impulsive in their decision-making and might go out and just start to buy something or do something without thinking of the consequences. If you think about what we do in rehabilitation, our goal is really to improve the quality of that individual's life and also the quality of their family's life. Brian Genet, who's a neurosurgeon and one of the creators of the Glasgow Coma Scale, put this nice list together of what affects quality of life. And really it is the same for those of us who are able-bodied as for people with disabilities. Is that those of us who are able-bodied frequently look at the disabled and say, well, it must be totally different, the issues. The issues are the same, and our goal in rehabilitation is how do I restore that self-esteem and respect and that quality of life. So the first is activities of daily living, and that's the ability to brush your teeth, wash your face, dress yourself. Simple things. And there's been studies to show that the highest correlation for self-esteem is with the ability to control your own bladder and bowels, something we all take for granted. But many of our patients with disabilities can't control their bladder and bowel, and it is a huge issue for quality of life. Every year, I'll have a man who may not go home and will go to a nursing home because he doesn't want to have his wife cleanse him and clean him after he's gone to the bathroom. The other is the ability to organize our life in mobility. Is that you're sitting here watching this tape and all of a sudden decide you don't want to watch it anymore, or you need to go to the bathroom, or you're thirsty. You turn it off, maybe you leave it running because you don't want to hear anymore, but you can control to get up and go where you want to go, when you want to go, and organize your life. People with disabilities can't always do that, so that our job in rehabilitation is to allow them to control their environment, to control mobility, to get up and get where they want to go, even if it's in a wheelchair, how to control the environment, the room they're in, and give back that control over one's environment and life organization. Social relationships, remember we talked about that which makes us most human, is the ability to make relationships. Now, we don't always form good relationships, and they may not be the best, but all of a sudden that person with the disability may have been taken out of the pool of people with whom they were having social relationships, so that no longer are they included in the group because they're different, and they may need to form a new social group, and that loss of social relationships, of people to go to the movies with, of people to date, of people to love and marry, changes drastically. And part of our job is to work on social skills and to recreate the fabric of those social relationships. Now, work's an interesting one, because we all complain about work. We all say if we won the lottery tomorrow, we'd quit work. But on the other hand, work is very much who we are. And very much who I am is what I do on a day-to-day basis. And if you take that away from me, you take away a large part of my identity. Now I have a disability or an injury, and my doctor suggests that they have a new job for me. And rather than being the medical director of a major rehabilitation hospital, I get to work at Wendy's putting the napkins together and the plastic spoons and forks. And I say no. So that the level of work is really important. And we get a lot of enjoyment and a lot of respect out of work. One of the things that Freud always had was a triangle, and it was the balance of life, which is to work and to love and to play. And that you need to have that imbalance in your life, in that if things are bad at home but okay at work, most of us can balance that, or vice versa. And then leisure activities are important. So we look at the last two, and the last two are really important and are really tough things for us in rehabilitation, but what we have to work on a great deal, and that's present satisfaction. Think of yourself, if you're able-bodied, or if you're disabled and listen to this, are you happy with your present situation? Are you satisfied? If yes, you have good quality of life. If you're unhappy, then that's a factor that you need to try and change. So part of our job in rehabilitation is to look at that individual with a disability and say, how can I improve their life so that they can be satisfied with their present situation? How can I give back that quality? And the last thing is really future prospects, and something we don't think about too often. But as I'm here making this videotape, also what I'm thinking about is I'm going to fly home. In a couple of weeks, we're leaving to go fishing in Idaho. Between that, I'll have dinner with my son, and then I've got another book we're working on. And so I'm planning for the future prospects. I'm planning on what's happening. And the key to rehabilitation is to give a future back to our patients so that they don't look at how I am today, but how I am in a month or 6 months or a year. And many people underestimate how important that future prospects is. And it's an important part of the rehabilitation work that we do.